for the National Center for Health and Public Housing. It's such a great honor to have you all. Just like a brief introduction, our National Center is one of the 20 HRSA-funded NCAs providing training and technical assistance to health centers, especially those located in or immediately accessible to public housing. On July 1st, 2017, the Bureau of Primary Healthcare announced all national cooperative agreements that we need to provide training and technical assistance to all health centers, regardless of whether or not they concentrate efforts on any of the special populations. In the past, there were NCAs providing training and technical assistance to health centers serving special populations such as homeless, public housing residents, or agricultural workers. Now, according to the new HRSA guidelines, now all NCAs need to provide training and technical assistance to the more than 1,400 health centers across the nation. As a result, this afternoon, or this morning if you are on the West Coast, in addition to the health centers that have the public housing primary care grant, we also have some health centers that are not public housing primary cares, but that they will be collaborating with us and providing their expertise on some of the topics we plan to discuss. The idea that HRSA has is to establish a learning health system. The 20 NCAs are working together. We've been having conversations and meetings with HRSA and NAC, and we are going to establish a national resource center, which basically you will be able to find all the resources and materials being created by the national cooperative agreements and primary care associations. The idea is that all toolkits, publications, webinars are part of a centralized system. So if anybody is looking for kind of best practices or any other training materials, they will be able to obtain it from that website. So before I go on, I would like to do a quick introduction and see who is on the call. I just need to make sure that everybody can hear me. If you not can hear me, there is this system has where you can send me some messages, but I'm not sure who can hear me and who cannot hear me. What I can see is that we have 9 people on the call. So let's start by my colleague here at the National Center for Health and Public Housing. Saki, can you hear me?
Hi, Jose. This is Saki. Yes, I can hear you. Hi, everyone. My name is Saki Malik Cho, and I'm the manager for policy research and health promotion here at the National Center.
Excellent. Thank you so much, Saki. And we have a guest from Massachusetts Primary Care Association. Perrin, I know that you've been having issues with the communication. Can you hear us? That's fine. I mean, it seems that she cannot communicate with us, but she can hear us. Thank you so much, Perrin, for being with us today. And she is with the Massachusetts League of Community Health Centers, and she will be participating on this call. And then we have Dr. Glab from
ECA Health.
Thank you so much. Can you please introduce yourself, Dr. Glab? I'm sorry.
Yes, good morning and good afternoon, depending upon where you are geographically. So my name is Dr. Glab. I am the medical director at TCA. We were one of the, I believe, one of the first housing projects in Chicago. And I will leave the rest of the presentation to our Dr. Leon.
Thank you so much. We also have people from San Isidro Health Center. Good morning. Can you hear us?
Good morning. Yes, this is April House. I can hear you. I'm the Vice President of Population Health here at San Isidro Health Center.
Thank you so much. Is there anybody else with you?
Not with me, but I can't confirm whether or not they've called in from a different area.
Okay. All right. Anybody else on the West Coast who has joined us?
Yeah, this is Joy Mark, Sonia Tuck.
Go ahead, Sonia.
Okay, this is Sonia Tucker from La Maestra Community Health Centers, and I'm the Chief Quality Officer.
Thank you so much for being with us. And who else is on the West Coast?
This is Joy Mockbee from El Rio Community Health Center in Tucson, Arizona. I'm the Medical Director for Family Medicine.
Thank you so much for joining us this afternoon. Anybody else? Am I missing anybody? Well, so I believe this. Thank you so much for being with us. And when I was talking, basically, we've been having conversation with HRSA. HRSA has three priorities right now. This is something that we got from the Bureau a few weeks ago when we met with them. And the three priorities are basically our strategic goals are increase access to primary health care, advance health center quality and impact, and optimize Bureau primary healthcare operations. The first strategic goal is to increase access to primary healthcare. And according to Jean McCrae, one of the areas to address is, why it's so important to address this area is because according to them, there is some kind of service area overlap. And additional health centers are moving from counting visits to counting patients. Well, this is a big step forward. Primary national cooperative agreements and grantees have pointed out that health issues such as addressing opioid addiction and substance abuse require a larger number of visits to reach desired outcomes. So we've been talking to them. These are some of the priorities, as you know, mental health and substance abuse, HHS and HRSA and all the other agencies are working. And this is some of the topics that we are planning to include in future conversations. The second strategic goal is basically advanced health center quality and impact. And diabetes is the main focus for HRSA. According to HRSA, diabetes presents an opportunity to make a big difference in health outcome and cost savings. These are some of the performance measures, and if you see from 2014 to 2016 there has been a reduction of 1%. Specifically, they are working on the A1 greater than 9 clinical performance measure, and the idea is to decrease the number from 29% of patients with diabetes to approximately 28% or 27.9%. That is a 5% decrease. That's the goal, and that's the reason why all NCAs and primary care associations are working and building all these learning collaboratives to share and gather best practices and share these best practices and have all this information in on a centralized website. So the patient-centered medical home recognition remains a high priority for HRSA too, given the connection between PCMH recognition and better health outcomes. According to this slide, 68% of health centers were PCMH recognized as of July 1st, 2017.
Excuse me, Dr. Leon.
Yes.
I hate to interrupt you, but I don't see those slides. I don't know if anybody else can see them. Maybe it's just me. I'm Dr. Glab.
Let's see.
I see the initial slide, NCA types.
So you don't see the other slides?
I do not. Maybe the other participants do, and if that's the case, I will be quiet and let you continue.
Let's see. Can you see my slides? Anybody? Can anybody see
This
my?
is April. I have the same view as Dr. Glab stated.
Okay, all right. So let me see. Well, what I'll do is that by the end of the call, what I'll do is I'm gonna share the slides with you, with everybody. And
Okay.
I'm very sorry. It seems that either the slide froze up on me or there is any other issues, but I am very sorry with that. And I'm gonna make sure that everybody gets all these slides.
Hey, Jose?
Yes.
This is Saki. Can I try taking over as presenter and going through the slides and seeing if people can see it that way?
Let's do it that way. Sure. Let me make you the presenter, Saki.
Does everybody see the very first slide, the National Center for Health and Public Housing title slide?
Yes.
Next, does everybody see the NCA types?
Yes.
Okay, there we go.
Are we? So you guys can see this, building a learning health center system?
Yes.
Okay, great. Jose, what slide are you on?
That is slide 9.
Okay. Just let me know when you want me to advance, okay?
All right. Go to slide 10, Saki, please.
Okay.
Okay, thank you, Saki. And this is what HRSA is trying to get specifically all, as I was saying, all health centers, primary care associations, national cooperative agreements are going to work to improve the diabetes outcome. And specifically, we are going to focus on the clinical performance measure, hemoglobin A1C greater than 9. And the idea is to bring the numbers to the Healthy People 2020 goal, which is around 61.2%. You can see the numbers from HRSA as of 2016. The diabetic patient with uncontrolled diabetes is around 32.1%. And we are trying to at least bring the number down by 5% by 2018. So that's the goal. And next slide, Saki, please. And the two main goals associated with the Diabetes Improvement Initiative are basically increase diabetes prevention efforts by increasing the percentage of adults and children who receive weight screening and counseling. Next slide, Saki. And the second goal area is focused on improving diabetes treatment and management. The desired outcome is to reduce the proportion of diabetic patients with a A1C value greater than 9% and increase the proportion of health centers that meet the Healthy People 2020 goal for uncontrolled diabetes for each racial and ethnic group. Next slide, Saki. To facilitate progress on these goals, the Bureau and the Primary Care Association and National Cooperative Agreements are striving to improve health systems and infrastructure, optimizing provider and multidisciplinary teams, and facilitate behavior changes in patients. Next slide, Saki, please. Now, in a recent conversation with the director of the Office of Quality Improvement at HRSA, Suma, she asserted that the collective health center program, including NCAs, primary care associations, and ACCNs, already have data, expertise, and resources needed to move the needle on diabetes outcomes. The question is how we can best deploy the resources so the outcomes can improve. So the idea that we have, as I mentioned, is to identify and highlight what's working well and it's not working well, and scale what's working well and spread successful practices. You will see that primary care associations and national cooperative agreements we'll be having all these kind of learning collaboratives to collect data, collect best practices, and share best practices with the other health centers. The idea that we have is to host these conference calls every 2 months, and probably every month I will contact you individually just to talk about other emerging topics affecting the special populations. For instance, we are going to focus on cervical cancer, substance abuse, and mental health. The last two, as you know, are HHS priorities. So your feedback will be posted to our website as monthly publications, and the calls will be recorded and also posted to our website. We are going to base all these conversations on the American Diabetes Association 2016 Standards of Care. We have also been in contact with the American Diabetes Association to discuss the standards, and the 2017 standard will be out by the end of this year. We are trying to invite some of the subject matter experts at the American Diabetes Association so they can share some best practices with the group. And in the meantime, the idea is to develop some content, and the content will be based on the ADA standards of care. So for this first call, I sent 2 documents, and this is the 2 topics that we would like to discuss this afternoon, and we are going to use them as a guide for a call. So before we get started, does anybody have any questions? So I take that as a no. Thank you so much. And we would like to talk a little bit about social determinants of health, prediabetes, and diabetes. And that's the very first topic. I sent some documents. I would like to hear from all of you. For instance, the very first question that we have is, if you can tell us what are the social determinants of health, specifically affecting the diabetic population in the state that you are in. So can anybody take that question?
Sure. I'm Dr. Glab at TCA. So we're in a housing project in Chicago, and we're in a unique location because we're about 25 miles from the center of Chicago proper, although we're technically in Chicago. So to address one of the big issues for our patients is access to fresh fruits and vegetables, especially in our pre-diabetic population where we really want to offset in childhood obesity. What occurred here in Chicago is they got a green veggie bus. This veggie bus comes once a week, I believe, and you can utilize through coupons that moms with young children and expectant moms WIC coupons to interchange purchase for some of these fresh fruits and vegetables. My CEO, Ms. Clark, is also working with the community to see if they can bring one of the big food chains here, particularly to this neighborhood, because a lot of the moms, even if they have cars, have 2 and 3 small children, and it's very hard to shop with young kids.
Great. Thank you so much. Sometimes we have conversations with the public housing agencies. We have conducted some needs assessments, and one of the issues that we have had from some of the specifically for some of the public housing residents is that in some areas violence is an issue, and sometimes, for instance, they cannot exercise or they cannot have any outdoor activities because of this. Is that a problem, Dr. Glab, for you?
I'm sorry, that they cannot be in other activities, like physical activities?
Like exercising or doing some outdoor activities?
Yes, and I'm glad you bring that up because all of us are affected by gun violence. And even our hours at the clinic have reflected patients' needs. They don't like to be out after dark. So we only have one late night and it's till 6:30. So the interesting thing that happens is our schedules are really jammed between 2:30 and 5 o'clock. And then once the sun goes down, it's even the late night that we have 6:30 is not really utilized. And that's something that I notice particular to where we are, is people are afraid to go out after dark.
Great, great. And now, do you have or do you offer any kind of exercise program?
Yes, we do. We
Okay.
do. We have a wellness program that is subsidized by one of the grants we have from an outside funder. And they have exercise classes at 5:45, 2 nights a week.
Great, great. Thank you so much. Now, Sonia, is there any thing that you would like to share with us? Sonia is with La Maestra Community Health Center in San Diego.
Yes, absolutely. I want to kind of share with you a little bit about what we do here at La Maestra. Even though we are basically a community health center, we also have a lot of social services in order to try to bridge those social determinants of health. And, the doctor was talking about, being affected by gun violence and so forth. I mean, it's the same thing that we have here especially in our City Heights location. Also is, we live in a food desert. So what we have done here to try to bridge a little bit of that gap is we have created a garden within our community where people can go and plant their own vegetables to be able to have, fresh vegetables at a very affordable, free price. And also we have created a program where our patients and also our prospective patients can come to our food pantry. So within our food pantry, when, a few years ago when I took over of helping the food pantry operations, we decided to get rid of any processed food with high contents of salt and sugar. So everything that we give is vegetables, fruits. So we understand that one of our issues also is homelessness in the area. So we want to be able to provide these particular foods for our homeless as well, so that they are able just to grab a fruit and eat a fruit if they want to, or a vegetable that doesn't need to be cooked. There is a combination of fruits and vegetables or vegetables that will need some cooking. But we are definitely trying to teach them, not only provide for them, but to teach them how to plant and grow their own fruits and vegetables. And then we partner that with our health education department and the program that we do in order for them to understand why we do the things we do. Not because we want, because it's our desire that you only eat fruits and vegetables, because it's the best for you. So we have a program that it was also tailored within our own organization, and we teach it at the provider level and all the way down to the food pantry. So we have a health educator that is available to answer any questions that people might have right there when they're picking up their food.
Excellent. Thank you so much. And as I understand that you have a very diverse population, and you have. I was talking to Zara the other day, and she mentioned the term that you have. Do you have these outreach workers from that community? So they speak.
Correct.
I believe that there are more than 20 languages.
Yes. So
if I'm not mistaken.
we speak 28 different languages and dialects, and it keeps growing as the refugees come to the areas where we work. And so what we do, that is also a good point, Doctor, that you make. What we do is we try to employ people from the community that understand their needs and understand their barriers. Because, a lot of us are also immigrants, but we come from a different background. So that not that we won't relate, but it will be difficult for us to understand what other people are going through or thinking that come from a different cultural background. So the whole idea that we also created what we call, instead of calling them translators, they're cultural liaison. So within our cultural liaison, they do also reach so that they can relate to the people according to their cultural and social background, so that the people don't feel foreign within our four walls.
Great, thank you so much. Dr. Mogby, is there anything that you can share with us?
Yeah, we have been working on screening for social determinants of health, and so we started off with some surveys that were administered by student volunteers, but have now expanded, and we're using a kiosk-based survey that patients fill out when they establish care, and then once a year after that, that asks a wide variety of questions around social determinants. And then depending on their responses, we connect them with our community health advisors, who then connect them with different resources in the community. So not just focused on nutrition, exercise, but really a broad spectrum of social determinants of health. And then we also have a lot of other projects going on around, we have family cooking classes, exercise classes. We have one of the pediatricians has just started a farm program where we have a local cooperative extension that actually has an urban farm, and they took about 40 of her patient families by bus from the health center to this farm on a Saturday, and so the kids got to pick vegetables, and then they had cooking classes of preparing the vegetables, and then she's having follow-up group visits with those same families, and so and then various other programs, but those are some of the main things. Or I guess the other big one is we're working with the National Park Service to prescribe parks, and so the Park Service is coming up with different kind of park descriptions of various fitness levels, and then we're having group activities in the parks so we can try to overcome various barriers.
Wow, this is really, really good. Thank you so much. Is there any transportation issues with your patients, Dr. McVie? I'm not sure if that is a rural area. So is there any transportation issues?
We're an urban area, but we're fairly spread out. So transportation definitely is a concern, which is why with the farm program, they provided transportation, even though it's relatively close. I mean, probably only about 4 or 5 miles away, but even that can be a big barrier. So for our park prescription program, we're really focusing on parks that are in the neighborhoods that we serve, but then also looking forward to doing some bus trips to our Saguaro National Park, which is fairly close by. And we do have transportation to the clinic so that we can try to work out transportation for the classes and family cooking classes. That's a little more complicated, but we do work on that.
Excellent. Thank you so much. Anybody from San Isidro who would like to weigh in on these social determinants of health?
Hi there, this is April. So similar to what a lot of the others have mentioned, we, experience the same characteristics within our population with the communities that we're in and the people that we serve. And so a lot of what we do is around education with the patients, and in particular, as you mentioned with transportation, we have a significant barrier with transportation, and that prevents an access to our services, which includes cooking classes and health education and those types of things, as well as events. So what we've done is try to take this to our communities where they are. So with a grant that was funded recently, we put some extra effort into how we can increase access to those services that would improve upon the social determinants of health, in particular food safety as well as medical access and those types of things. So what we found in collecting that data is that we're able to identify communities or areas of the community where many of our patients that seek care here are located, and we host events where they are. So we essentially take what we're trying to get them to come into the clinic to receive to them. So we found that to be helpful, in particular when working with our promotoras in the community as well. they design their own culturally specific classes and information for those that we see. So that's been actually really helpful in addressing some of the issues that present that really create those inequities and the inabilities to receive all of the services that we do provide.
Great, great. Thank you so much. And do we have anybody from ZUFO on the line? Okay, I believe we don't. And one of the questions, and this is something that NAC and all the primary care associations are working on, is on how you collect social determinants of health data. Dr. Mugby mentioned some of the tools that they use. Is anybody using or collecting determinants of social determinants of health data?
Yes, this is Sonia from La Maestra. So we have been collecting social determinants of health in, La Maestra for as long as I can remember, as long as I know, 27 years or so. Initially was embedded within our own templates in the EHR. We were, adding features in the different templates to try to collect transportation information, language information, and just demographic information in general, and mining the data. So lately we have been able, and I was going to ask if anybody has used the prepared template. So we use NextGen as an EHR vendor, and NextGen came up with a social determinants of health template that we're utilizing now. The whole idea is to have a central point where we can put all that information in and everybody can have access to it. In the past, we were using our EHR, but we were also using 2 other different softwares where we were collecting data for also our non-patients or clients. So we have our outreach department that goes out into the community, and the people that they encounter with, they don't necessarily need to be our patients, they're just clients, but we also want to know the social determinants of health for those people, since eventually they might become our patients. So we were also using that software that we customized for our own need, and we were asking all the questions that literally are now within the template that we have in our EHR.
Excellent. And sorry, just to well, this is a follow-up question. You mentioned the NAC tool. Are you using that prepare tool?
Template, correct.
Okay.
Yes.
And is that
we're using prepared template? Yeah.
Yes, exactly. All right.
And that's what we're also using at El Rio.
Oh, okay, perfect. I was going to ask you, Doctor.
Thank you so much. Great, thank you. Now let's move on. Once you collect the data, do you use this data to basically follow up on patients? Do you create some kind of guidelines for these patients? We conducted a needs assessment in 2016, and this is one of the questions that we asked, whether or not first you collect social determinants of health data, and the second is what do you do with the results once you analyze the results? Have you created any diabetes program or any training for the patients based on the data that you collect?
This is Joy from El Rio. We haven't done that in a large way yet. We're really focused on connecting individuals, but that is one of our plans, is that once we have enough data over time to be able to look at trends and then provide advocacy around whatever issues we find.
Excellent.
In our case, this is Sonia from La Maestra. In our case, under diabetes, we in fact are working right now to try to use predictive analytics and analyze not only what the possible outcome would be, we've used the information that we have, but it's basically clinical information. We try to incorporate a little bit of the social determinants of health to see if we're able to utilize that information and be able to find out what can we do. So we did design, we incorporated our pharmacy. Our pharmacy was able, by the readability level, by the education level of our patient, kind of tailor or help the provider to tailor a treatment plan for, and not as specific for the patient, but for certain patients with certain characteristics. And we have been able to increase our compliance rate in about 18 months by about 5 or 6%. We're mining the data right now. We're hoping that we can do more work into with the information that we are collecting right now to see how we can increase that compliance. And all this has been done around diabetes, and we're hoping that at some point we also can utilize the same tools around pre-diabetic patients as well.
Excellent, excellent. Thank you so much. Dr. Glab, are you also collecting social determinants of health data? Probably we lost Dr. Glab. Okay. Now the other concern, this is something else that we got from our latest survey, is the collaborations between health centers and community organizations. For instance, those who are who got the public housing primary care program are working with the public housing agencies. If the special populations that you serve are homeless, then you may be working with some of the homeless organizations in your state. Are you working with either the public housing agencies or any other state or local organizations to address social determinants of health, and specifically regarding diabetes? Anyone from San Isidro, April? Nobody? Someone from South End Community Health Center in Boston? Dr. Mugby, do you have anything to share with the group?
Not around public housing or specifically around diabetes. I mean, we do have teams that go out to homeless shelters and rehab centers and other outreach sites, really with the intention of providing immediate care and then linking people to our health homes. And we've had some talks by some of the housing agencies just about what options are available in the community, but we don't necessarily have any kind of formal program with them.
Okay, great. Thank you.
On the same token, La Maestra does something kind of similar. We have partnered with, the police department, and especially, I don't know, I'm sure you guys have heard with the hepatitis outbreak that we have had in San Diego. Has been a wonderful partnership because we go to the patient, whatever they are. A lot of them, the homeless population, they don't want to come to us because of whether they're ashamed, they don't want to lose. It's unbelievable when we ask them, they don't want to lose their place where they have their belonging in that area of the street or whatever area they are. So we have been able to have very successful partnerships with different organizations in order for us to be able to go and outreach to them take the social services or the medical and social services that they need and link them to care. Obviously, we would love for them to come to our health centers, but also we have partnered with other community health centers in the area that might be more convenient for them to go and see the provider there. So we just want to make sure that they are educated and that once they see a provider the first time, they don't feel that barrier of going and see another provider.
Okay, great. Thank you so much. And now I'm looking at the list of participants, and some of you are muted. I'm not sure if that's the reason why we cannot have conversation, but I see some of them, some of the names are muted. So if you would like to say something or share your experience, can you please unmute so we can...
Hi, Jose. This is Subarna Mukherjee. I'm the quality manager calling in from South End Community Health Center in Boston. I think my colleague told me, I had actually just stepped out of the room for a second, and she told me you had called our name. So yes, I wanted to remark, I've been listening to the conversation so far, and we have a very basic outreach kind of relationship with the housing projects that are located close to our health center, where we have basically been tabling and sharing our services and that our health center exists for the population, but we are very interested in growing and expanding the work that we do there. So we're in a very exploratory phase of learning how we can best partner. And then, just to add on, I think a lot of the ideas in terms of, we haven't really formally started doing social determinants of health assessment, but, we are aware that food insecurity and housing instability are two of our primary challenges working with the patients here. And so we do have wellness groups, we have a fruit and vegetable produce truck, but we haven't really thought of a cohesive kind of program to address the needs of this population yet. So I'm interested in the next few calls to learn and hear what others are doing.
All right, thank you so much. And I'm not sure if you can see the next document that I would like to share, but in the conversations that we had with Prime Manager. In the conversation that we had with the American Diabetes Association, when we were talking about diabetes and a patient with diabetes, they asked the question that if health centers are using diabetes risk test with their patients, that's something that I would like to ask. This is a question that we got from the American Diabetes Association.
I'm sorry, what was the question?
If there is any diabetes risk test that you use when you have a patient that is at risk of diabetes, or either because they have family history or because they are obese or they have any other condition. Let's see if I can, I don't know if you can see my screen right now. Probably this is too small. But is there any risk test that you use, any document that you use with your patients so they can assess whether or not they are at risk of diabetes?
This is Joy. We don't have a particular screening tool questionnaire, but we are very aggressive about identifying and following prediabetes, which clearly is a big risk factor. So we screen consistently for diabetes and prediabetes, and then we really try to follow the prediabetes closely.
Excellent. Thank you so much. Let's see if I can somehow upload this document so you can see this. Okay. Okay. Now, anybody else, how do you assess any risk of diabetes? This is a question that we have received from American Diabetes Association, whether you use a diabetes risk test or what is the process, and if the test address social determinants of health. Somebody from San Isidro? Dr. Glab, are you with us? All right. We have other questions, and this is more about the second document in regards to this is the document on strategies for diabetes awareness, prevention, and control. And what is the process when you have a patient with prediabetes? For instance, do you have any kind of multidisciplinary team once you have identified a patient with diabetes or pre-diabetic patient? And what is if there is a if you have any case management who offers health promotion and address the social determinants of health and all the food insecurity, housing, and all that stuff? Sonia?
Yes, I'm sorry. Yes, we do have a process. So the process is basically when the patient gets diagnosed with prediabetes, immediately the provider will send a referral for our case manager. So we have a case manager and an RN case manager. The RN case manager will look into what we can do for the patient, more education, sending the patient to our health education department, so that we can assess what the knowledge of the patient in regards to their condition is. And then we follow up with the patient every 3 months from that point, and we enroll them in our program, and we make the case manager available to them, not only the case manager, the RN, but also the health educator, who goes over 6 different classes, and we teach them how to read labels, how to lose weight, how to count calories, just basic information. And we have had a pretty good success. We have a couple stories of patients that have come to us and have expressed how that particular very simple approach, but very useful approach, has helped them to go from pre-diabetics to lose weight, and to be completely controlled and in compliance. And the patient and the provider is also involved, just making sure we want access to care as well, which is one of the, I think, major issues that we are all dealing with. So we want to make sure that we're not going to waste the patient's time and the provider's time. So that's why we have a multidisciplinary team approach. In some cases, we have also utilized the behavioral health department, but it's in very individualized cases, and it depends on what the providers assess on that particular patient. But it has also been utilized where the patient sometimes needs to go to behavioral health to understand what is going through, what their body is going through at that point.
Great, thank you. Thank you so much. How do you get? This is a question that all health centers are always interested. Sonia, do you work with your state health department or any other organizations to fund these programs, to get additional funding?
Yes, we do. Of course, I think we all in community health centers, we all are huge in grants, but also having, trying to figure out what is reimbursable and what is not reimbursable. Trying to look at, okay, so, a certified diabetic educator for, Medicare, it is a reimbursable visit at a very low cost, but a reimbursable visit.
You know, and it really just leaning on partnerships is basically what we try to do. The idea is that we break even, but we rely a lot on different funding sources that comes from grants that we grant.
Okay. Okay, thank you so much. And Dr. Mugby, I attended the Association of Clinicians for the Underserved conference, and there were some very nice presentations from a Rio Community Health Center. And specifically, there is a program for diabetic patients in regards to lifestyle interventions and exercise. Can you share a little bit about this program?
Yeah, so we have two different but complementary programs. One is our diabetes exercise and education program, which is for people with prediabetes and diabetes. And it is a series of group visits that primarily focuses as the activity on exercise, because what we found was that we weren't really getting anybody to show up for our nutrition classes, but people were coming for our exercise classes. So what we did was we basically rolled our other services into the exercise class. So we capture them for the exercise, but we also have our dietitian attend, our behavioral health consultants, and our clinical pharmacists. So people are really getting this very robust program all rolled in while they're also doing exercise. So it's twice a week for 6 weeks, and then some people continue attending various iterations of the course. And then and we also have a beginner level and advanced level, because what we found was the people who were continuing in the program, their fitness was so much improved that the new people weren't able to keep up, and the older people were getting frustrated. So we also have a weight first approach, which we're really expanding throughout the whole health system, really trying to get all the primary care providers to focus on managing weight first. And then we have our formal weight management program, which is the medical weight management program, where we systematically offer people the interventions that are evidence-based for their weight and comorbidities. So for some people, that's medications, all with lifestyle, so lifestyle plus medications, or lifestyle plus surgery, and some cases, a combination of those, maybe lifestyle medications and surgery. So with a high-intensity program, weekly for 12 weeks as the core series, and then monthly follow-ups with the weight management specialist or the PCP.
Excellent.
So, and ongoing.
And if a health center is trying to implement this program, how can they do it, Dr. Mugby? Is this through the state? Is this through a federal organization?
Yeah, I mean, I think the key thing is that there really is mounting evidence that for diabetes and for many other chronic conditions as well, that if we treat weight aggressively and up front, and not just with lifestyle, but with other assistance, and with realistic goals. So at least a 5%, really a 5% weight loss is very impactful as far as multiple chronic conditions. And so with the focus on that, that we can achieve better outcomes. And so I think it's a lot of education of the primary care providers, and then having support from the whole team as far as the dietitian and exercise specialists and behavioral health consultants are really critical pieces. So the Obesity Medicine Society is really a great resource for all team members and especially providers. And so I think by really having more team members attend their CME courses and possibly get certified in obesity medicine, it can really improve the effectiveness of the programs.
Great. Thank you so much. And now, Saki, do you have any questions for our colleagues here? Any question that Saki is taking some notes, and probably she may have some questions.
Hi, Jose. Thanks for that. Actually, I've been taking lots of notes, and I'm planning on writing this all up. And if I identify additional questions, I might reach out to you at a later time. But right now, I don't have any. Thank you so much.
Thank you, Saki. And now, is there any thing that we can hear from South End Community Health Center? I'm not sure. We still have South End Community Health Center on the line. Do we have it? Do we have you, Subarna?
Hi, yes, I'm still here. Sorry, what was the question?
I mean, if there is any program or intervention program that you have in place and that you are using with your pre-diabetic and diabetic patients.
Well, we have attempted to use focused wellness groups through our nursing diabetes educator, but we have faced some language barriers. So although there was interest in it, we have kind of run into a roadblock because we need to find staff that Spanish-speaking staff to lead that group. So we have kind of slowed down on that, but we are hoping to resume it once we kind of resolve the staffing challenge.
Thank you so much. Now, it's 1:58 Eastern time. I want to be very mindful of. We are going to have additional health centers who are going to join us. We have 2 grantees from Puerto Rico, but due to the Hurricane Maria and all the efforts that they are working on, basically they were not able to join us. But so far, and we have 12 health centers, and the idea is to get at least 15. So probably next. When we have the next call, we are going to have participation from other states and from other HHS regions. So I would like to thank you. We are going to share the notes with you on the additional topics that we are planning to include. Is there any last minute comment or topic that you would like to discuss? All right. Thank you so much. Have a good afternoon or the rest of the day if you are on the West Coast, and thank you so much for participating on this call. Have a great day.
Thank you, doctor. Bye-bye.
Bye.
Bye.